Welcome to our main track online forum. This is the first one of four in 2025. My name is Svenja Frista. I'm working as a doctor at main track, and today I will be your moderator during this presentation with the topic assessment of tumor aggressiveness and risk of recurrence in cancer using stemtrac with our lecturer, Professor Dr. Pachmann. She is the founder of Matrix and as a medical doctor, the chief scientist at the Laboratory Pachmann in Bayreuth, Germany.
Thank you, Svenja, for introducing me. And I want to talk today about the stemtrac approach for assessment of tumor aggressiveness and risk of recurrence. The most frightening part of a malignant tumor is the ability to form metastases. How are metastases formed? The tumor cells can detach from the primary tumor or from already existing micrometastases and enter the bloodstream. They are called circulating tumor cells. In the bloodstream, they can survive, settle in other locations, and start growing again and form metastases. It's believed that metastases mainly originate from circulating cancer stem cells. The stemtrac is designed to detect circulating cancer stem cells. How do we proceed? Cancer stem cells are a subpopulation of tumor cells that have stem cell properties, that is, the ability to self-renew and differentiate into a heterogeneous cancer population again. These stem cells are assumed to be responsible for relapses and metastases. They are more resistant to conventional chemoradiotherapy and make thus current treatments in part ineffective. Strategies to eliminate the cancer stem cells are a central topic in cancer research. And as you can see on the lower left, the stem cells are a part of the tumor and may not be eliminated by treatment and then can repopulate the tumor or metastasis and form the threatening part of the tumor. The stem cells are detected from primary tumor by the expression of cancer stem cell specific surface markers. This is done by flow cytometry or immunohistochemistry. And they have the LDH1 enzymatic activity, which can be used to test for this activity and help to detect the stem cells. And then there's the tumor sphere assay, because cancer stem cells can grow as unattached spheres in 3D culture, which distinguishes them from regular cancer cells. And in addition, they can be grown in mouse models as patient-derived xenografts, which is a very cumbersome approach, and as patient-derived xenografts on the chorion allantoic membrane, the CAM model, which is very fast and which we use to verify that the stem cells are able to grow into tumors. How do we proceed to detect the cancer stem cells? So you send the blood to us, and then the red blood cells are lysed, and the tiny white sediment, that's the white blood cells, and they can then be put into cell culture flasks, and some of them grow into these spheres shown here, and these can be detected microscopically, and this is typical for cancer stem cells, which we detect from circulating cells. We have published this already in 2016 and shown that these cells are a predictor of the presence of metastasis in patients with breast cancer. What are they looking like? They grow continuously from day 7 to 21. Day 7, we can detect them, and they exhibit the typical phenotype of cancer stem cells, and they express the epithelial antigen. And so far, we have not been able to grow tumor spheres from healthy subjects. So this is scanning such a sphere, and you can see the cells lying in different layers of the sphere. They also exhibit the typical markers, which are also shown from tissues. That is, these spheres are CD24 negative or low positive and CD44 high positive, and they are typically expressing high activity of the LDH1 enzyme. The clinical significance of these cells is shown by the fact that the number of spheres is increasing with increasing stage of the tumor, and that tumors where metastases have been detected have much higher numbers of tumor spheres as compared to those with metastases. And in addition, those with single metastases have much lower numbers of tumor spheres than those with multiple metastases. In addition, patients with HER2/neu positive breast cancer have much higher numbers of circulating spheres or sphere-forming cells than those who are HER2 negative, and they are in Ki67 low positive tumors. There are much less sphere-forming cells than in the Ki67 positive tumors. So the number of tumor spheres is associated with the proliferation index of Ki67. So this is how we detect these spheres and how they are correlated to clinical stage. And do you have any questions so far?
There is one quite interesting question at the beginning. Can you please point out the difference between circulating cancer stem cells and the circulating tumor cells?
Yeah, that's a question that is often asked. I will show during the cases which I will present that there are cases where there are stem cells present, but no epithelial circulating cells detectable. There are many cases where they correlate, and there are cases where there are many circulating epithelial cells, but no stem cells, and I will discuss this in the following cases. So, assessment of tumor aggressiveness. Here, there is a patient who had neoadjuvant chemotherapy. It was a triple negative, highly aggressive primary tumor, 30-year-old female. Initial diagnosis in June 24, Ki67 high, and we analyzed her in a status post-neoadjuvant chemotherapy, surgery, and radiotherapy. And you see that after completion of the treatment, she had a high number of circulating stem cells, which showed that she is at highly increased risk of metastasis, and she indeed has now developed metastasis, which is not shown here. So the next one is triple negative, again, highly aggressive primary tumor in a 36-year-old female patient. Initial diagnosis 04/24. She did not well respond to the neoadjuvant treatment, had still higher Ki67 after the neoadjuvant treatment, and we looked at her numbers post-neoadjuvant chemotherapy, and since December 24, she is under adjuvant treatment with a checkpoint inhibitor. And as you can see, she had very high stem cell numbers, at the beginning of pembrolizumab in agreement with a low response to the neoadjuvant treatment. And these numbers now have decreased somewhat, but are not really low yet, although she has this treatment with the checkpoint inhibitor. So this again points to that she is at a high risk of soon relapsing. Now, another case, breast cancer under endocrine treatment with tamoxifen, a 47-year-old female patient with breast cancer. She had her initial diagnosis in March 24. She had a small tumor with a low Ki-67. We analyzed her at the status post-surgery, and indeed, she had very low cancer stem cells at the beginning of observation, and she has remained very low now under the treatment of tamoxifen. During maintenance therapy, the patient maintains a consistently low number of tumor spheres, and she remains in complete remission. Another patient with KRAS mutant colon cancer, initial diagnosis in 04/21, and she had a big tumor with involved lymph nodes. We observed her in her status post-surgery and post-adjuvant chemotherapy with FOLFOX, which was performed from June to October 23. At the beginning of the observation, she had very low circulating cancer stem cells, remaining low even without treatment, and again now very recently, and this patient is in complete remission. So I've shown you some patients with high risk of recurrence and two with low risk of recurrence. Are there any questions?
There is, I think, a two-part question. Does a biopsy release cells from a breast tumor into the circulation? And are cancer cells also potentially released from a breast tumor if the margins are reported as good?
Actually, we find that the cells can be released, but we can't really show that they are released by biopsy. We see that there can be cells released by different treatments, especially we have published after surgery, but we have no statistical analysis regarding the release during biopsy. It's known that in some cases with very aggressive tumors, there can be the channel of biopsy can have metastasis, but we would need to more closely look at that. The most prominent is the release of cells after or during surgery.
Do you have any cases in whom the cancer stem cells are not detected after chemotherapy?
Yes, we do. But the problem is that cancer cells can return into cancer stem cells and the other way around. So that's not a stable condition. The circulating epithelial tumor cells can also reverse into stem cells. And that's why we have to monitor them continuously.
Regarding tamoxifen, if the patient stops tamoxifen or is at the end of the therapy, is there any increase in circulating cancer stem cells or circulating tumor cells? Is there any danger in coming off?
That's exactly a question which we will try to answer in a controlled study, but I will show during the next cases where after the end of tamoxifen therapy, stem cells and circulating cells can increase. This has been correlated to relapse, and we all know that after the end of endocrine therapy, there can be relapses in the patients. And that's the question, who should stay on endocrine therapy for longer times and who can terminate it. And I'll show you an example in the following cases.
One last question for this round. How can circulating cancer stem cells be eliminated?
A very important question, which we can't definitively answer yet. There are approaches to eliminate them, and we can also test on the circulating cells or on the spheres developing from these circulating stem cells, whether a substance is effective against these cells or not.
Right, so every drug can be tested?
Any drug which is in question, yes, we can test different substances.
Thank you very much. We will go on with the presentation.